Hi, it's Tally from First Aid for the USMLE Step 1. Let's shift our discussion now to talk about respiratory pathology. DVT is very high yield because it's the primary cause of pulmonary emboli, which we'll talk about next. So, do you remember Virkel's triad from the hematology talks? Sure you do. Patients are predisposed to the development of DVT on the basis of venous stasis, hypercoagulability, and endothelial damage. In other words, you are getting inappropriate activation of the coagulation cascade. So what types of case presentations on the boards make you think of DVT? Well, classically, you would think about orthopedic trauma patients, or really any patient who is immobilized for a period of time. Other folks at risk including older patients, women who are pregnant or postpartum, people taking long plane trips or car trips, cancer patients, and women on birth control pills. Holman's sign is tenderness of the calf muscle with passive stretch such as dorsiflexion of the foot and can be an indication of DVT. However, Holman's sign is usually not very sensitive or specific, so you usually try to make the diagnosis with duplex ultrasound of the extremity in question. Now, don't feel bad if you ever miss the diagnosis. I have a close relative who is an academic orthopod who missed the diagnosis in his own wife who was postpartum with calf pain. Patients with DVT are commonly treated with heparin, low molecular weight heparin, and warfarin to keep the clot from expanding and greatly reduces the chance of a pulmonary embolus. This venogram is from a 15-year-old girl taking oral contraceptives whose left leg became severely swollen after a long plane ride. As you can see, there is proximal obstruction of the left femoral vein, propagating to the distal inferior vena cava with multiple dilated collateral vessels. The topic of pulmonary emboli is a classic boards and wards topic. You will talk about this all the time as a third-year student with any pain who has sudden onset of dyspnea, chest pain, and tachypnea. There are a number of things that can embolize to the lung arterial vasculature, and that's pretty much summarized here by the fat bat mnemonic. Fat emboli classically occurs with long bone fractures and liposuction. And if a woman presents just after delivering a baby with stroke and shortness of breath, what should you be thinking? Amniotic fluid emboli, which in addition to pulmonary embolism can also lead to stroke, an anaphylactoid reaction, and DIC. What's DIC again? Disseminated intravascular coagulation, as discussed back on page 360, is where there is widespread activation of the clotting cascade leading to bleeding, bruising, and kidney failure. That being said, most pulmonary emboli come from deep vein thrombosis of the legs. Here is a pulmonary embolism that came from a femoral DVT in a 60-year-old male who presented with sudden death. This is a massive saddle embolus blocking the pulmonary artery, so you can see why this was a fatal event. In the right image, you can see that the clot was formed sometime prior to death with the lines of Zahn, where you have pale layers of platelets mixed with fibrin alternating with darker layers containing red blood cells. The first step in diagnosing a pulmonary embolus involves having a high degree of suspicion. In the ER, you usually will not see too much with a chest x-ray or ECG, so CT pulmonary angiography for visualizing the pulmonary vasculature is the test of choice. Here's a cross-sectional CT scan that shows a large filling defect in the right pulmonary artery of a 60-year-old woman with colon cancer and sudden onset of shortness of breath. So here's another huge topic for the boards, and it's a big group of diseases in general. How big, you ask? Well, COPD alone kills more than 125,000 Americans each year. I don't want to be overly dramatic about this, but it's 40 times the number of people who died in the 9/11 tragedy. To understand obstructive lung disease, it's important to understand forced vital capacity and forced expiratory volume in 1 second. As we discussed earlier, forced vital capacity is measured by spirometry, and it's the volume of air that can be forcibly exhaled in one full expiration. The patient is asked to inhale as much as possible and then exhale as much as possible. FEV1 is measured in a similar way, but it's only the volume of air that can be forcibly exhaled in the first second. By definition, obstructive lung disease involves obstruction of airflow with air trapping in the lungs. During exhalation, the airways close prematurely at higher lung volumes than normal. This therefore results in increased residual volume and decreased forced vital capacity, since less air is able to leave the lungs. Think for a moment about the diagram of lung volumes on page 546, and think about how obstructive lung disease would affect lung volumes. pause the video for a second if you need to. We'll talk about this a little later when we compare obstructive lung disease with restrictive lung disease. In obstructive lung disease, you classically see a decrease in FEV1. Since FEV1 decreases to a greater extent than FVC, the FEV1 to FVC ratio also drops, which is a hallmark of obstructive lung disease. Since these patients also have decreased ventilation due to a lower vital capacity, they have decreased ventilation and increased perfusion, or a VQ mismatch. So let's discuss COPD, asthma, and other forms of obstructive lung disease. Patients with chronic bronchitis can be thought of as blue bloaters. This is one of the most common types of COPD. The pathology involves hypertrophy of mucus-secreting glands in the bronchioles, which can be quantified with a Reed index greater than 50%. The mucus and inflammation causes the obstruction, which causes the body to decrease ventilation and increases cardiac output, creating that VQ mismatch. You may also see secondary polycythemia. These patients classically present with a chronic cough for greater than 3 consecutive months per year for at least 2 years. They also have wheezes, crackles, and cyanosis from shunting and dyspnea on exam. You might also see signs of right heart failure, which gives them that swollen, bloated look. When you think of emphysema and also chronic bronchitis, what's the very first thing that should come to your mind? Tobacco smoke, of course. So with smoking, you get this characteristic destruction of airways and terminal bronchioles, classically called century acinar, before spraying peripherally. This leads to decreased recoil and increased compliance in the lungs, and presents with dyspnea, decreased breath sounds, tachycardia, early onset dyspnea, but late onset hypoxemia, and eventually wasting. The pink puffer look comes from the effort to puff through pursed lips to increase airway pressure and to prevent airway collapse during exhalation. Other morphologic types of emphysema include panacinar emphysema caused by alpha-1 antitrypsin deficiency, which is very board testable. Normally, what does alpha antitrypsin do? Well, it inhibits neutrophil elastase from breaking down elastin. So no alpha-1 antitrypsin means more breakdown of elastin in the lungs, which leads to the panacinar emphysema. You can go back to the GI section on page 335 for more information on alpha-1 antitrypsin deficiency. Finally, there's erysipetal emphysema, which is frequently the cause of spontaneous pneumothorax due to bullae rupture in tall, thin adolescent males. So how is asthma different from COPD? Asthma is classically caused by bronchial hyperresponsiveness, leading to reversible bronchoconstriction, whereas in COPD, the obstruction tends to be fixed. Now remember, there's a spectrum of disease where you can have a bit of overlap between these two conditions. The classic pathology associated with asthma is smooth muscle hypertrophy, airway inflammation, and mucus plugging. Kirschmann spirals are shed epithelium that is a byproduct of the mucus plugging. You can see the obvious corkscrew shapes here. So if you looked at the sputum of an asthma patient, what else could you see? Well, you might also find Crayola bodies, Charcot-Leyden crystals, and of course eosinophils, especially in allergic asthma. What do eosinophils do in asthma? Eosinophils release major basic protein, which causes epithelial cell damage and bronchospasm. In allergic asthma, you also see Th2 cytokines like IL-4, 5, 10, and 13. If you don't remember much about these cytokines, go back to page 200 in the immunology section for a quick review. The findings of an asthma exacerbation are cough, especially at night, along with wheezing, dyspnea, and tachypnea. Finally, we come to bronchiectasis, which is a permanent, irreversible dilatation of the proximal and medium-sized bronchi. This condition may present with purulent sputum, recurrent infections, and hemoptysis. Causes of bronchiectasis include necrotizing infections with bugs like Staph and Klebsiella, bronchial obstruction, poor ciliary motility, Cartaginer syndrome, cystic fibrosis, and allergic bronchopulmonary aspergillosis. Here's a chest x-ray of a cystic fibrosis patient with bronchiectasis, scarring, and mucoid impaction. Note that he has relative sparing of the left lower lobe. And here you have coronal CT in a patient with recurrent and chronic pneumonia. You can clearly see the dilated bronchi, especially on the right side. So we spent a lot of time discussing obstructive lung disease. Now let's talk about restrictive lung disease. As you'll remember from our discussion of different pulmonary function tests, restrictive lung disease has its own characteristic pattern. As a result of restricted expansion, lung volumes such as FVC and TLC are decreased. But what happens to the FEV1-FVC ratio? Unlike obstructive lung disease, the ratio is usually preserved because patients don't typically have any problems emptying their lungs. They just have less volume to exhale. It's useful to think of restrictive lung disease in two ways. First, think of the mechanics of breathing and the different components involved that aren't the lungs themselves. Poor muscular effort in such conditions as polio and myasthenia gravis can result in restrictive lung disease. Similarly, conditions that physically restrict the volume capacity of the lungs, such as scoliosis and morbid obesity, which is one of the most common causes, also fall into the restrictive lung disease category. Interstitial lung disease, which affects lung parenchyma, are restrictive lung diseases that also negatively impact the diffusion capacity of the lungs. So how do we measure diffusion capacity? Remember from the respiratory physiology talks on page 549 that we said that carbon monoxide is a gas that is diffusion limited. In other words, this gas equilibrates slowly across the alveolar capillary membrane in the lungs and is not affected by the cardiac output like nitrous oxide, which is perfusion limited. So in this test, we ask patients to breathe an air mixture with a small amount of carbon monoxide. Then we measure how much carbon monoxide is taken up. The result is expressed as a percent predicted DLCO, which stands for the diffusing capacity of the lung for carbon monoxide. A low percent predicted value would indicate a diffusion problem that would affect oxygen uptake. Interstitial lung disease usually causes pulmonary fibrosis, which you can see as honeycombing throughout this image. There are many examples of interstitial lung disease that are discussed here, including ARDS, neonatal respiratory distress syndrome, and the pneumoconiosis, all of which we will discuss shortly. There's also a long list of drugs that can cause direct lung toxicity, fibrosis, and restrictive disease, and we list a few here. Can you think of any other examples? I would also add nitrofurantoin and cyclophosphamide as drugs that might also get tested. Here's a case of pulmonary fibrosis caused by amiodarone toxicity. Note the fine reticular nodular pattern of the chest X-ray. This is the typical look for most of the interstitial lung diseases. The pneumoconiosis are high yield and are likely to show up on your boards, so watch out. These pathologic states involve alterations in the normal lung parenchyma as a result of exposure and response to foreign substances such as coal, silica, and asbestos. Anthracosis is also known as coal miners' pneumoconiosis or black lung disease. The inflammation and fibrosis from the coal exposure typically affects the upper lobes. As with all pneumoconiosis, you can expect certain complications such as right heart failure and something called Kaplan syndrome. So what is that? Kaplan syndrome is a mix of rheumatoid arthritis and pneumoconiosis in people with intrapulmonary nodules seen on chest X-ray in a homogeneous pattern. Silicosis is also known as Potter's rot or grinder's disease. This is associated with exposure to the byproducts of mining such as foundries and sandblasting. In this disease process, the presence of silica causes the production of hydrogen peroxide and other oxygen radicals that damage the lung tissue. Alveolar macrophages take up these particles and release cytokines such as TNF, IL-1, and leukotriene B4 that lead to fibrosis and the characteristic eggshell calcifications in the hilar lymph nodes. Silicosis is also associated with tuberculosis and bronchogenic carcinoma, which are both board testable. Asbestosis is perhaps the best known pneumoconiosis, especially because of all those late night commercials. Attention! If you or a loved one has been diagnosed with mesothelioma, you may be entitled to financial compensation. Of course, the lawyers left out bronchogenic carcinoma as another major association. So what is asbestos? Well, it's a silicate mineral that was used for a lot of things, including insulation, fireproofing, and soundproofing. Therefore, you typically saw exposure in industries like shipbuilding, roofing, and plumbing. Unfortunately, exposure classically caused calcified pleural plaques. In particular, the stray fibers are more carcinogenic than the curved ones. Now, unlike the other pneumoconiosis we've discussed, asbestosis typically affects the lower lobes of the lung. As seen here, the asbestos bodies, or the ferruginous bodies, are basically asbestos fibers that develop a ferritin protein coat with a dumbbell or beaded appearance.